Hi, everybody. Today we are talking about taking care of the family after delivery. So for the family after delivery, we're really thinking about, especially for the postpartum mom, it's kind of her care through the whole continuum of postpartum. But for the baby, we're going to be thinking about that transition period or the fourth stage of labor, the things that are happening in the first couple of hours after delivery. For our mom, when we think about our assessment, where when you do a head to toe assessment, you're still assessing all the same things, and then we're adding in this extra stuff. And so bubble heat is a way to remember those things. Your breast, your uterus, your bladder, your bowel, lochia, episiotomy, hormone sign, and emotional status. So we're going to kind of go down the list thinking about these items. So for the breasts, when a baby delivers, remember that the progesterone was maintained the pregnancy, right? And so the progesterone drops for labor and birth. And when that drop happens, it triggers the body to release prolactin. Prolactin is a hormone that is going to encourage the breast to start filling with milk. Okay. Also, then when we are breastfeeding, then we end up with kind of a loop where oxytocin tells the milk to let down, prolactin tells the breast to fill. So every time a baby suckles and empties the breast, then the breast will make more milk. So oxytocin is the hormone that tells the milk to let down. And so this is actually really good for a postpartum mom also, because that oxytocin makes the uterus contract. So we were using that in labor, potentially, and now the body's doing this on purpose. Colostrum is the early milk. This is what comes in first. Moms most often can express colostrum even before their baby's born. And colostrum is really thick and high fat. It's really high in protective antibodies, and babies don't need much of it because when they're newborns, their stomachs are very small and they don't need a lot to eat. But the colostrum is going to give them everything they need until the milk transitions to mature milk. And that usually happens about 3 to 4 days after delivery. Okay. It can be a little sooner, a little later, but that's kind of our ballpark. So because that the breast is going to trigger milk production every time the breast empties, if a woman is planning to not breastfeed, she should not stimulate her breasts at all. Okay, because every time the breast empties, it's going to make more milk. So no nipple stimulation. Don't do warm water like in the hot shower. Those things help milk let down. Ice packs are good for the discomforts of engorgement, because when the milk first comes in, the body makes so much because it doesn't know how much the baby needs. So it just makes a whole bunch. And the breast can get really tight and uncomfortable and engorged. So ice packs are good for that. And then analgesics like ibuprofen. Um, So for the breast, if she plans to breastfeed, we want to start getting that baby on the breast soon after. So usually within the first hour. Okay. And there's a lot of things like the baby friendly initiative with hospitals and stuff that say that we need to try to offer the breast in the first hour of life. And that's also going to be a really good time to do some good teaching with moms about getting a nice, good, deep latch and showing them the best way to latch their baby, because nipples that become cracked and blistered are going to decrease mom's desire to breastfeed. It can be very painful, and it impairs the ability for the baby to get what it needs from the breast. So, a good latch is important. For engorgement, we just said is when the milk first comes in and the breast can get very hard and uncomfortable. So this is usually 24 to 48 hours with engorgement. If she's planning to breastfeed, we still can do ice packs between feedings to help with that. Okay. But If you want to encourage her to like take a warm shower before she feeds, that's going to help her milk let down. It's also going to keep her breast clean. We're not encouraging moms to wash their nipples with soap because that can cause cracking and dryness, but just water is fine. So for your breastfeeding mom, frequently feeding during the engorgement period, she can hand express some milk to relieve some of that extra pressure. She can use a breast pump if she would like. Even just wearing a supportive bra can make a big difference. Okay. And then there's mastitis. Mastitis is an infection that happens within the breast. And so it's usually on one side and it can become a systemic problem. So she will have fever, she'll feel like flu-like symptoms, just feel really kind of not good. And the breast will be very tender. And we want to the baby can still feed on that side, but we want to use it gently. We want the breast to be emptying. We don't want that to stay stagnant in there. But it might be more ideal to have her offer the unaffected side with breastfeeding first when the baby's more vigorous, and that might help with her discomfort. And then she can also do ice packs. She can also do analgesics like ibuprofen, things like that. And then oftentimes these moms are also on antibiotics. For the uterus has been this organ that has this muscle that has let this baby grow inside it. And when the placenta separates and comes out, all of those vessels that have been feeding the placenta are now exposed. And the uterus's job after the baby and the placenta are delivered is to contract and clamp down and squeeze and tamponade those vessels. And then the uterus stays contracted and it keeps contracting and going down slowly back to its pre-pregnant state. And this is involution, the return of the uterus to where it was before it was pregnant. If the uterus doesn't do that, if it fails to return to its non-pregnant state, that's subinvolution. Oftentimes, subinvolution is caused by something inside the uterus that's keeping it from contracting well. So typically, this is either going to be retained placental fragments, or it can also be infection. So the infection that we worry about in the postpartum period is endometritis, which is an infection of the endometrial lining of the uterus, typically where the placenta was attached. So these things can cause the uterus to not contract down and return to its pre-pregnant state, and this can actually lead to a hemorrhage. So it's important that we are giving good teaching about what should be happening with her bleeding even after she goes home, because that can also be an indication, which we're going to look at in a minute with Lochia. Okay. Inversion is when the uterus gets turned inside out. This is thankfully not common, but a couple times that it happens, one can happen during delivery if the delivering provider is putting a lot of traction on the cord to help encourage the placenta to come out. Sometimes it can kind of pull the muscle down with it. The other time that this can happen is when we're doing fundal massage, if we're not doing a good job supporting and we're pushing hard from the top. So with fundal massage, we are going to put, like if this is the belly button, we're going to support from below and then we massage from the top. Okay, on the fundus. And so if we're massaging hard, maybe she's having a lot of bleeding and we're giving really good massage trying to get the uterus to contract well, then we could invert the uterus, which would be really bad. If the uterus turns inside out, it can't contract well, it's going to bleed, it's a hemorrhage issue, mom can go into shock, lots of pain, and oftentimes she ends up back in the operating room. And they give a medicine to relax the uterus, then they put the uterus back in place, and then they immediately give oxytocin to make it contract. Contractions. So this is compression of the intramyometrial vessels. This is where we said the uterus needs to squeeze and tamponade those vessels. So a couple of things, the mom's body we just said with breastfeeding is releasing its own oxytocin. And then and so that's her endogenous oxytocin. And then we also give exogenous oxytocin, which is the medicine we give, usually IV, and the two together are going to really help the uterus contract and control the bleeding. This though can cause cramping and pain, and it's going to be especially noticeable for the mom when she's breastfeeding, because when she latches the baby, uterus contracts more because of the oxytocin. And so sometimes if moms are having a lot of cramping and discomfort with breastfeeding, we will try to time their Tylenol or ibuprofen around feeding times. So this is what I was talking about with fundal massage. Okay. So the uterus needs to stay contracted. It needs to be firm. And so when I feel it, it should feel hard, right? And right after delivery, I anticipate finding the fundus of the uterus somewhere around the belly button. It can be a little bit up or down depending on mom's habitus. So if she has a high BMI, sometimes she has a large pannus and it kind of draws her belly button lower, so that then we might be feeling it in a different place related to her belly button, things like that. But for the most part, the belly button is our landmark. And we are going to, when we do check the fundus, we can check and make sure it's firm, and we can apply a little bit of pressure, but we don't need to do a lot of really strong massage unless we're really worried about her bleeding. So we're checking to see where it's located. We expect the belly button. If it's above the belly button, those are pluses. And we're thinking about the width of your finger. So if it's one above, like if this is the belly button and I feel the fundus here, that's one finger width above the belly button, so it would be +1. If I feel it below the belly button, it's -1, or however many fingers. And it should be in the middle. It should be midline, okay? If I am checking and I'm finding it at the belly button midline, and then later it's like 3 above and deviated to the right, that's an indication of a problem, which we're going to look at in a second with bladder. So the fundus should then start going down daily. And so each day it should go down by at least 1 finger width. And that is involution. Okay, so if that's not happening, then we have to assess and figure out why. So for our bladder, right after having a baby, women have a decreased urge to void. Oftentimes it can be related to the numbness from their epidural, but not always, because the nerves that go to the bladder have now had a lot of pressure and stretching happening to them with the birthing process. And oftentimes the bladder just doesn't feel, it doesn't notice those sensations for a bit. True also that since the baby's been putting pressure on the bladder before and now that pressure's not there, that also can change their sensation for a little bit. So it's important that we're keeping an eye on her bladder and we're managing this, because postpartum diuresis happens where we, after the baby is born, then the body starts diuresing and it starts reabsorbing some of that fluid it hung on to. She's needing to pee, and her bladder's getting more full, and maybe she doesn't feel that her bladder's full. So if the bladder becomes distended and full and she doesn't notice it, we are going to have the potential of having an increase in bleeding, because if the bladder puts pressure on the uterus, and then the uterus, that's where we can see we were checking it and it was at the umbilicus, and now we're finding it above the umbilicus and deviated. That's a good sign the bladder's full. And when the bladder is pushing up on the uterus doesn't think it needs to contract. It's feeling that pressure and it stops contracting in those spots. And so it can now be a cause for some serious hemorrhaging if the uterus becomes atonic. Okay. So Another thing that can happen too if the bladder is distended is the more full it gets and the more distended it gets, the harder it becomes for her to empty it. And stretch injuries and things like that are also a concern. So for all of these reasons, we encourage women to void. Spontaneous voiding should be within 4 to 6 hours. Most hospitals have a policy regarding this. And so they have a whole plan in place depending on if the bladder has, if the mom is able to void within 4 hours, and then they might do a bladder scan, they might straight cath, they might do different things to keep that bladder from being too full. The other thing too is that if she does start hemorrhaging, managing the bladder is one of the first things we do. Okay, we massage the fundus, manage the bladder, give medication to make the uterus contract. So the bladder plays a big role for a lot of different reasons. The other thing we think about though with the bladder is that as she has labored and birthed, there's can be some pelvic floor trauma, and this can cause her to have stress incontinence after delivery, and even beyond going home from the hospital. And so oftentimes we're teaching Kegel exercises to help strengthen those muscles for urination. For the bowels, it takes a little bit of time for normal elimination to occur, but we really need to be mindful, especially for our moms that have had 3rd and 4th degree lacerations, to keep the bowels moving. So it can take a few days for total normal function to resume, but we're going to be encouraging ambulation. We're going to be encouraging high fiber diet. We're going to be encouraging hydration. I say that. Fluids, ambulation, high fiber diet. We need to also consider stool softeners. And for women that have 3rd and 4th degree lacerations, oftentimes they will also give a laxative like Miralax or something like that to keep those stools moving easily and to minimize trauma, because the 3rd and 4th degree laceration is the tear that goes all the way to or through the rectum. Okay. And because of that, we also don't want to use things like suppositories and enemas and stuff like that. So we really need to avoid constipation as much as possible. But a woman who just had a baby has so many reasons to be constipated. We're potentially giving narcotics in labor. She might be dehydrated. She might have hemorrhoids. There's a lot of things. And then also kind of fear. They are nervous to poop. Okay. If she had a C-section, oftentimes gas pain is a big problem for women after a C-section, just because the air can get in there. And so for your patient that's having excessive gas pain, we can give things like Gas-X or simethicone, and encourage ambulation, have them rocking, things to try to keep air moving. And the thing with this is sometimes they feel gas pain in the normal place, sometimes, so it can be referred to the shoulder. And then you're concerned, is this gas? Is it something else? Okay. So this is lochia. Lochia is the post-birth discharge. And what we anticipate happening is that in the first few days after delivery, lochia is red because it is primarily made up of blood. Okay. And so this is called lochia rubra because rubra means red. Right. After the first few days, it should transition to a more pinkish color. And this is now a combination of some blood and mucus. And so this is called lochia serosa, this pinkish. And the pinkish color is going to go from starting in the first few days after delivery and lasting up to 2 weeks after. And then it's going to transition to a clear whitish color. And this is mostly now mucus, and this is lochia alba. Important to note, guys, that what it should make this transition, it should go rubra serosa alba. If it goes rubra serosa rubra, That's not what's supposed to happen. And so that can be a sign of subinvolution. That can be a sign that we have retained placental fragments or membranes, that we have something going on that is keeping the uterus from doing what it's supposed to do. And that can be an indication of a late postpartum hemorrhage. So we need to make sure that she knows to be seen if that happens. During the postpartum period, when she's at the hospital, and actually we teach this when they go home too, we are looking at how much lochia she's having, and we're quantifying that. And so we can weigh pads if we are really concerned about volume, but we also can teach to how to look at their pads and to know if it's light, if it's moderate, if it's scant. If she is saturating a pad in an hour, that's too much. And so she should notify. If she's saturating a pad in less than an hour, definitely too much. Okay. If she's passing clots, clots that are bigger than about the size of a golf ball are genuinely concerning. But typically we ask them to tell us about clots that are even smaller than that. Just let us know if you're seeing clots and let us see them. Okay. Also, we want to know if there's an odor. Lochia shouldn't have a foul smell. And if it does, that can be an indication of infection like endometritis. So excessive bleeding, this is going to be the thing we worry about. Okay, as far as in the immediate postpartum period and after she goes home, because if there's two types of hemorrhage. There's your early hemorrhage that happens in the first 24 hours. And that's usually caused by uterine atony. The uterus is atonic. It's not contracting like it's supposed to. And those hemorrhages tend to be much more significant in blood loss than your late hemorrhage. So your late hemorrhage is from 24 hours after delivery all the way up to 6 weeks postpartum. And those are going to be caused by subinvolution. And so that's what we were just talking about. Like if the lochia goes back to rubra, and things like that. Also, if the uterus is not coming down, if you palpate a uterus a week postpartum, it shouldn't still be at the umbilicus or whatever. Like it should have gone down. If we're going down a centimeter a day and a week out, it should have gone down so much that it's difficult to palpate it. Okay. So postpartum hemorrhage is the leading cause of maternal morbidity and mortality. Normal blood loss for a vaginal birth is going to be 500 mL. So anything more than 500 mL is too much. If she had a cesarean, then they say greater than 1,000 mL is too much blood loss for a cesarean. Okay, they allow some extra for the fact that it's surgery. So we can see a continuous flow of bright red bleeding. We can see a passage of large clots saturating more than a pad in an hour. Okay, if she is bleeding, our very first vital sign change we're going to see is her heart rate. So tachycardia first. Definitely hypotension also will happen because she's going to start showing signs of hypovolemia. But the very first vital sign we see is tachycardia. Okay, so in the first 24 hours, we said the most frequent cause is uterine atony. The uterus is not able to contract down and maintain good tone. So this is where we want to massage the fundus to encourage it to contract, and we want to manage the bladder so that we can make sure that it's not boggy because the bladder's full. So if the uterus is displaced from midline and it's up from the umbilicus, then that's usually a good indicator that the bladder is the cause. But even true, if I'm finding it midline, I'm still going to manage the bladder. So if she's hemorrhaging right now, I'm going to put in a catheter. But if I just go in to assess her, she's sitting there, she's feeding her baby, I massage her fundus and I just check her fundus, I find that it's boggy, I might massage to get it to contract, and then I might also consider having her void. I'm not going to get her up though if she's bleeding, if that makes sense. Okay, but if it's boggy and she's not bleeding yet, I might have her void. So it just depends. The other thing that can cause excessive bleeding in the postpartum period are going to be lacerations and hematomas. So hematomas, you're not going to see the bleeding, right? Because the blood is collected in the tissue. It's building up in a pocket. And so most of the time this happens in the vulva. And it can get very large, and it looks like it has a bluish bruised look to it, and it swells in that area. And she will typically exhibit a lot of pain at the site. So if I see tachycardia and I'm not seeing blood on the pad, I might want to assess for hematoma. Okay. Now for a laceration, lacerations can happen with birth, and if they're not found and not repaired, then they can continue to bleed. And so with a laceration, what you'll often see is you check the fundus and it's firm, but you're getting this constant trickle of blood on the pad. And so that's kind of a good indicator then. If we have a constant trickle of blood happening and the fundus is firm, then that's a good indication that we should have notify the provider to look for lacerations that are unrepaired in the vagina. So bleeding management, we're going to massage the fundus. We're going to, expression of clots kind of just happens as you're massaging the fundus, but also the provider might go in and actually manually try to pull out anything that's inside there and grab those clots as well. Because if there are clots sitting in the uterus, that's going to affect its contractility also. We want to eliminate bladder distension. So have her void, put her on a bedpan. Truly, at this point, she's bleeding. I'm not getting her out of bed, and I'm probably not putting her on a bedpan. I am putting in a catheter to keep that bladder empty, so it's not putting pressure on the uterus. We need to establish or maintain venous access. So she probably still has an IV from labor. I might put in a second line. Okay, if she's bleeding, I'd like two, because if for women that are having a hemorrhage after delivery, they can lose so much volume so quickly. And so having two IVs is ideal. And then we can be giving fluid boluses and meds through one, and we can be giving blood products through the other as needed. Okay. The goal is going to be to maintain stable vital signs so that we can oxygenate the tissues. And so we can be using, again, IV fluid and blood products, and that'll be established by the provider. And you'll have a lot of nurses in the room working on a lot of different things. The other thing is our medications. And so if uterine atony is the problem, we need to make the uterus contract. And so oxytocin is going to be being given IV, but we have other uterotonics we can use. So uterotonics are going to make the uterus contract. They're going to improve uterine tone, okay? And so the medicines we will use for this, one of them is misoprostol. And misoprostol is a medicine that we use in tiny doses to induce labor. But in large doses, it helps the uterus to contract, which is what we need right now. Hemabate is another one that can be given. It's given IM, but it is contraindicated if your patient has asthma. Methergin is another one that is a good choice to help the uterus contract. It's also given IM, and it's contraindicated if your patient has hypertension. So the thing to think about for this is that if your patient is hemorrhaging right now, she may not be hypertensive right now. But if she's been hypertensive before the bleeding started, we shouldn't give her Methergin. Okay. If we cannot get the bleeding under control pretty quickly, then they may use surgical management options. And so we can take her into the operating room. We can place a tamponade balloon, which the balloon goes inside and fills with fluid, and it tamponades those vessels. There's a new one out now that actually does the opposite, where it applies suction in the uterus, and so it makes the uterus clamp down on itself that way. We can do interventional radiology, where they actually go into the vessel and they block the vessel that is feeding the uterus. But if we cannot get a handle on the bleeding very quickly, hysterectomy is the option. sadly. Well, it's not common, but sometimes we have to actually take the uterus out to save her life. So on our bubble HE acronym, Holman sign is included, but truly, guys, we're not really doing Holman sign anymore. So Holman sign is designed to determine if a patient has a DVT or a deep venous thrombosis in the calf. And the way that it's done is by flexing the foot. But if she has a clot here and I flex the foot up, then I am risking dislodging this clot. And if I dislodge the clot and it travels, then now we have a risk of pulmonary embolism, which is a way bigger problem. So you might still see this done, but we aren't teaching people to do it anymore. So I want you to still know it, but that's not the best way to assess for DVT. Okay. So if a patient has a venous thromboembolism, then they will typically have warmth, and at the site that's affected, it will typically be larger than the other calf, and oftentimes the pedal pulses will not be equal. Okay, so these are other things we can do to assess. So remember, guys, that pregnant ladies are hypercoagulable, and this is also true in your immediate postpartum period. So for that reason, if you have a patient that's been on bed rest for a long time, maybe she was on magnesium sulfate, she was preeclamptic, she wasn't getting up much, or she had a C-section, then getting those patients ambulating as soon as possible is going to help reduce the risk of venous thromboembolisms. The other thing we think about, though, is going to be, I kind of called this slide coagulation, because that the opposite can happen too. And so if we just talked about the hypercoagulable part. However, if we think about our hemorrhage patient, this girl that we were just talking about here, she can develop an opposite problem. And this is called disseminated intravascular coagulation, or DIC. So when someone is having a lot of bleeding, and so this can happen during pregnancy with a placental abruption, it can also happen in the postpartum period with hemorrhage, the body can kick into this consumptive coagulopathy. And so what happens with that is all of the clotting factors get used up. And they're not used for things we actually need them to be doing, but now all the areas that need clotting can't. And so we get widespread bleeding. Internally, externally, everything's bleeding. IV site can be bleeding, injection sites can be bleeding, there could be blood in her urine. She can have petechiae where the blood pressure cuff was, like everything. And then we start seeing signs also of the hypovolemia. So tachycardia, diaphoresis, stuff like that. Okay, so episiotomy and lacerations. Episiotomies are not performed as often. So more often now, laceration can happen instead, because the body gives the space it needs for delivery. The healing for this is going to be the same as any other surgical incision. So we're going to want to watch it. We're going to use RETA, right? So redness, edema, ecchymosis, discharge, and approximation. So we can inspect. With her on her side, we can just kind of gently look at it that way. And we need to encourage the patient to keep the area clean. And so we're going to teach her how to use a peri bottle, teach her to change her pad every time she goes to the bathroom. And then we can give her ice packs to help with bleeding and bruising in the area. Okay. There's other, oh my gosh, other things we can also do. Witch hazel pads and benzocaine spray are both nice things that can help with that discomfort. We can do sitz baths and different stuff, but for the most part, ice packs and peri bottles are the best place to start. Also, consume a high fiber diet. Why? So think about what we just talked about on a previous slide when we were talking about resuming bowel function. We don't want her to get constipated. So high fiber diet is going to help. Attachment and bonding. So as nurses, we are watching how patients are attaching to their babies and how they're bonding with their babies. Skin to skin is the best thing to promote bonding in the immediate postpartum period. And so the baby is delivered up to the maternal abdomen and probably dried and stimulated right there on mom. And then assuming that the baby is doing well, then baby's tucked in skin to skin. Throughout the whole hospital stay, though, we're encouraging rooming in, and we're watching for behaviors that facilitate or promote parental attachment. So we're watching that they're touching their baby, holding their baby, talking to their baby, participating in care, participating in feedings, doing diaper changes, wanting to learn, all those things. If we see inhibiting behaviors that are hindering or preventing their attachment to their baby, that can be concerning. And so these are things that are often documented throughout their hospital stay. For emotional status, so we're going to use a screening tool. Typically, we use the Edinburgh Postnatal Depression Scale. And often this depression scale is even given to moms before delivery to get a baseline. And then we do it in the hospital before they go home. And if they score high on the postnatal depression scale, then depending on the location, they are evaluated for signs of postpartum depression. Things that can increase postpartum depression are going to be people that don't have a lot of support, people that have a history of anxiety and depression outside of pregnancy have an increased risk of postpartum depression, things like that. So if we see that they're not bonding well and interacting well with their baby, that can be a warning sign. And we're teaching about things like loss of appetite, difficulty sleeping, and things like that. And then typically they should be screened at the pediatrician clinic when they take their baby in at the 1, 2, and 4 month visits. So here's our different breakdown for emotional status. Up to 85% of women will experience what we call baby blues. And this is going to be some sadness and anxiety and emotional liability. It is transient because of the changes in hormones. I tell women they're going to feel a little bit like a 13-year-old girl for a while. The hormones get all out of whack and then they resolve. With your baby blues, your patient is still attaching to her baby and is still interested in taking care of her baby. Where with postpartum depression, oftentimes we see detachment. So postpartum depression is going to be last longer. Baby blues usually resolves by like 10 days after delivery. Postpartum depression, the symptoms might start out similarly, but they get worse and worse and worse. So she still can have labile mood swings and difficulty sleeping and loss of appetite. But in this situation, she's not really interested oftentimes in taking care of her baby. You can see signs of detachment. Oftentimes not really interested in taking care of herself either. Sometimes these women can have thoughts of self-harm, and that doesn't mean that they're acting on it. They just feel kind of worthless. This typically lasts more than 2 weeks and needs intervention. It doesn't usually disappear without some help or medication. And so definitely important to provide good education and offer resources. Okay. Postpartum psychosis is an actual disorder that has psychotic features. So it's common for women who have bipolar disorder it's more common for that. But in this situation, we see a rapid onset of very bizarre behavior. They can have auditory hallucinations, they can hear voices, they can see things, they can be paranoid, they have very kind of bizarre beliefs like that their baby is a demon and they have to save the world. And so these women have a really high risk of impulsivity for suicide and infanticide. And when you hear stories of women who killed their baby and killed their families after postpartum, after delivery, that's what this is postpartum psychosis. There was a really sad story, I want to say about a year ago, of an actual labor and delivery nurse with postpartum psychosis, and she knew something was wrong and she kept trying to seek help and she just wasn't getting what she needed. And the plan was for her to not be alone with the kids, and for whatever reason, her husband left for like 10 minutes and she killed them all. Very sad. Parenthood. So there's different ways that the dads versus the moms adjust to being a parent. So maternal adaptations we see for moms, we see first the taking in phase. And this is when moms are willing to let others do things for her. She's kind of overwhelmed with everything maybe. And she's okay to let other people do some stuff. Then the taking hold phase is when she really starts to slip more into that mother role and she's interested in caring for her newborn. And then letting go phase is giving up on previous lifestyle, giving up on previous birth expectations, and being in the moment to for what she has now. We had talked in another class about how women can actually grieve the absence of the birth process that they had expected. So letting go phase is now putting that aside. Okay. For fathers, they have expectations and personal intentions. They go through confronting reality and overcoming frustration, creating one's own personal father role and reaping the rewards of fatherhood. So this is a transition period for them as well, where they kind of go from what they thought it was going to be to what it really is for them. Because I feel like fatherhood is kind of an abstract concept until they actually have the child in their arms, right? So, and then for siblings, depending on the age of the sibling is going to depend on kind of how this happens, how this transition happens in their family with a new baby. Toddlers often regress, so they might start wetting the bed again or things like that. And so we're teaching parents that that's normal, or if their preschooler comes to see the baby and it doesn't really want to touch the baby or whatever, that's also normal. And all of these things just take some time. So for grieving parents, this was also discussed in a different week on kind of how we cope with this. So we need to be mindful of the parents who are grieving, in that we need to just give them some time and space. We need them some private time with the baby. We're working on creating mementos for them to take home. We need to normalize the grief process for them. We need to still be doing our normal assessments for her in the postpartum period and watching her bleeding and all those things, but definitely being very sensitive and doing the minimum that you need to do. Like, it's a hard line to cross because you definitely need to keep her safe, and you definitely need to monitor the things we monitor in the postpartum period, but especially good to kind of cluster your care and give her what she needs in that way. Allowing them to talk, express their thoughts, their feelings, often their guilt. Oftentimes women think that it's their fault. Allow them to be parents. So this is where you can let them dress the baby, bathe the baby, anything that they want to do, and as far as that's concerned, and really just normalizing all of the things that they're going through and providing them with resources. Health promotion for future pregnancies. There's a few things we're going to do for this. So if she was rubella non-immune, this is a good time now after she's delivered to give her the MMR vaccine. This is a live virus, so she couldn't have it while she was pregnant. So now I know she's not pregnant. She should avoid becoming pregnant for 28 days after she receives the vaccine, for the same reason as that we didn't want to give it while she was pregnant. We don't want any of those effects to affect forming baby. This is given sub-Q. It does not interfere with her ability to breastfeed. Signs and symptoms of side effects for the rubella vaccine are usually just localized to a little bit of warmth, rash, things like that in the injection site. Sometimes though, because this is a live virus, she can develop a little bit of a fever as well. Okay. Varicella vaccination, the CDC recommends that if she's non-immune. I'll say that in the areas that I've worked in, I haven't seen that we're giving this in the postpartum period, but definitely can happen if she's not immune. Again, with this one, she needs to avoid becoming pregnant for 28 days. Tdap. The Tdap vaccine is should be given to all adults caring for the baby because pertussis in a newborn is horrible. And oftentimes as adults, we don't know if we have it. It just feels like another respiratory infection. So anybody that's caring for a baby should be current on their Tdap. Moms are typically provided a Tdap vaccine during pregnancy. But if they haven't gotten one yet, they should get it. And also true the dad and anybody else like the grandparents. RhoGAM. So RhoGAM is going to be what we give to our moms that are Rh negative if the baby is Rh positive. And so this is going to suppress an immune response of mom's body to building up antibodies towards the positivity of the baby she just delivered. And that is going to affect potentially future pregnancy. So if she got pregnant again and the next baby was positive, if she didn't have the RhoGAM, then she has a high incidence of having antibodies that have built up. So that's what the RhoGAM is for. Okay. They typically get RhoGAM at 28 weeks gestation, and then they get it within 72 hours after birth if the baby's positive. And moms that get RhoGAM can get a little bit of a fever and have a little bit of a headache and some tenderness at the site. If your patient is a Jehovah's Witness, there's a strong possibility that they will decline the RhoGAM. So we need to give good education for why it's recommended, what the risks would be if they declined it. And some hospitals even have a form that they have them sign that they've been educated. Discharge teaching for mom. We want her to tell us if she has a fever greater than 100.4 because we would be worried about infection. We're going to have her call if her lochia goes back to rubra or if it has a smell. Bright red bleeding, especially if the lochia was serosa rubra and now we have, serosa alba, and now we have red bleeding again. If she's having prolonged after pains, pelvic or abdominal pain, constant backache, any signs and symptoms of urinary tract infection, so urgency, frequency, burning, pain, redness, and tenderness of the calf, localized breast tenderness, especially unilaterally, redness to the breast, any discharge, pain, redness, or separation of a suture line, whether that's your C-section, incision, your laceration, or episiotomy. If her signs of postpartum depression are getting worse, so if she is not enjoying life, she's having her feelings are worsening, then she should call. And then any visual disturbances. So we learned about preeclampsia and the way that it happens and in pregnancy, but very interestingly, some women can develop preeclampsia, the actual symptoms of it, after they've delivered. And so if they're having visual disturbances, then that can be a sign, and or severe headache or things like that, then they should call. So here, this is put out as an example of post-birth, and this is put out for patients. So this is an acronym of things, danger signs of when to call. Pain in the chest, obstructed breathing, seizures, thoughts of hurting yourself, bleeding, incision, red or swollen leg, temperature, and headache. So moving on to nursing care of the baby. So now we're going to be mostly thinking of those first 2 hours, or the 4th stage of labor, right? And this is the beginning of your newborn transition. So when the baby is first born, we are going to assign APGAR score. And our APGAR score is taking into consideration these things: the appearance, the pulse, the grimace, the activity, and the respirations. And for each of these categories, the baby can get 1 point for if they sort of do it, and 2 points if they totally do it. And so, and no points if they don't do it at all. So very normal for a newborn in the first minute to still be kind of blue all over, so they might not get any points. For the pulse, we're looking at if it's greater than or less than 100. For grimace, this kind of is how your baby's responding to stimulation. If you're stimulating the baby, they're kind of pulling away and have good flexion of their extremities and kind of making burrowed face and things like that. Activity, how's the baby moving around? Are they really moving around? Are they sort of moving? Are they limp and floppy? And then respirations, do they have a good strong cry? Are they breathing well? Are they struggling to breathe? Are they not breathing at all? Okay. And so when we give this score to all babies at 1 minute of life, and again at 5 minutes of life. If the score is 7 or more, then we don't score anymore after that. If the score is less than 7, we will continue scoring every 5 minutes up to 20 minutes after birth if needed. And so this is going to help guide us on what to do. So if we have a baby that has an APGAR score that's less than 7, it depends on what it is. If the APGAR score is 6, maybe I'm just gently stimulating the baby. If the APGAR score is 2, maybe I'm doing a lot more than that. Okay, so it just kind of depends on where we're at. When I go to a delivery, I'm gonna put my gloves on, and I want to know before the baby's even out, is this baby term? Do we have meconium stained fluid? Are there any pre-existing conditions I need to know about that would affect the baby? Does the mom have group B strep? Was she adequately treated? How long has she been pushing? How does the tracing look? Okay, so then the baby comes out. When the baby comes out, the baby's delivered to mom's belly, and we start drying and stimulating the baby. If I use the suction, the bulb syringe suction, I'm going to suction the mouth first and the nose second. Because if you suction the nose, then the baby's going to gasp and suck in whatever's in their mouth. Okay, so suction mouth first, nose second, and we're assigning APGAR scores at 1 minute and 5 minutes. If the heart rate's less than 100 beats per minute, or I see signs of respiratory distress, I need help. So I'm calling a provider. And then we also are going to encourage to clamp and cut the cord and take the baby to the warmer so that we can really do what we need to for the baby. But again, if the baby is on mom and has an APGAR score that is below 7, but isn't necessarily as concerning, I might just gently stimulate baby on mom. Because if I can get that baby to cry, everything else is going to improve. But true, even if the score is lower and we take the baby to the warmer to try to do more things, we're still stimulating the baby as one of the things to do. Because again, getting that baby crying and breathing is going to be a big focus. Okay, so don't ever discount the importance of gentle stimulation. All right. If baby's on mom, we're going to cover the head to help keep in heat. We'll do any of our assessments right there on mom's belly or on her chest. Then we look at the cord. We see that we have 2 arteries and a vein, or if we don't. And then, because once in a while you can have a 2-vessel cord, and that can be something that we document and we assess different things for. We're going to get cord blood. And so oftentimes the delivering provider just gets this for you, but it depends on where you're at. And then the cord blood goes to the lab and it looks at the baby's blood type and the RH, which is going to especially be important if mom's RH is negative. If our baby is very compromised at birth and has a very low APGAR score, we might also do cord gases. And so they can take up a segment of the cord and we take the blood out of the artery and out of the vein, and we can look at those lab values, and it can give us an idea of if our baby was very acidotic at birth. So I guess I don't have this set to run. Oh yeah, I do.
She brings that. She's gonna breathe. She's gonna. She is. Okay.
Yeah.
They're trying to say
Oh.
that's the gentle stimulation.
Look at all. Beautiful. What is not cramped? What is not?
The baby's color was a little bit bluish initially when we saw kind of the backside of the baby. I don't know if I can find it here. You can see, like, look at the shoulder. And so this is what we're talking about with color. But then as the baby starts to cry, the baby starts getting pinker. Okay.
Oh.
What is not clear? Let's see the.
Yeah, let's leave the cord. Oh.
So guys, if I were taking care of this baby at birth, I would, even without touching this baby, I can look at this baby and I can tell that we have good color, we have good tone, the arms are flexed up, the baby's crying, I have sort of a good grimace. I don't know what the heart rate is, but I'm going to say it's probably over 100 based on how the baby's responding. So we can still see a little bit of discoloration in the hands, and so the baby might lose a point on the APGAR score for that. But I can look at this baby right now and tell you I'm not worried. Okay, this baby's going to get an APGAR score that's greater than a 7. So this baby is totally fine to stay on mom. Okay. So signs of respiratory distress. If a baby is having difficulty breathing, there's a few things that we'll see. So we can see nasal flaring, where the outside edges of the nostrils kind of go out. Intracostal or subcostal retractions. So along the rib cage, it can suck in when the baby's trying to breathe. Grunting with respiration. So grunting is a sound that happens as the baby breathes out, and it's almost like a humming sound. And it is the baby working to get the air out. Okay. Substernal and subclavicular retractions. So underneath the sternum, we can see it sucking in, also up here by the clavicles. Stridor or gasping. Hypotonia. So the baby can be kind of floppy. Seesaw respirations. So babies are abdominal breathers, and so the belly and the chest should rise and fall at the same time. With seesaw respirations, the baby's working hard to get air in and out, so you see them alternating between the abdomen and the chest. Changes in color. So central cyanosis. Now, acrocyanosis is normal. Acrocyanosis is those hands and feet having the bluish discoloration. But if they're cyanotic in the trunk or in the face, that's concerning. Tachypnea is another big sign of respiratory distress. So this is a respiratory rate greater than 60 breaths per minute. And this is often seen when we have things like inadequate fluid clearance. So thinking about maybe our C-section baby, right, that didn't get a good chest squeeze coming out, or our precipitous labor that also didn't get a good chest squeeze on the baby coming out, that helps clear that fluid. Those things can increase our risk of tachypnea. Also certain infections and other issues. We can also see tachypnea with meconium aspiration syndrome, where the baby had stooled and passed meconium in utero, and that meconium mixed with the amniotic fluid and the baby actually aspirated the meconium. Then tachypnea is also seen with that, and that can cause pneumonia for the baby. So wet frog is a way to remember all of our signs of respiratory distress: wheezing, effort, tachypnea, nasal flaring, retractions, oxygenation, and grunting. And really, most everything with babies gets better if we get them breathing. So if we're having respiratory distress, we need to fix it. Thermoregulation. So do not discount the importance of maintaining the baby's body temperature. Okay, the thermoregulation is very important. So we, if babies get cold, they use more oxygen, they use more glucose. They continue down a cascade where they can be like hypoglycemic and all sorts of problems. Okay, after respiration and circulation, thermoregulation is the most critical to baby survival. So skin to skin is great. It's not only going to help with bonding, but it's going to help promote thermostability for the baby. And if I have a baby that's chilly, the first thing I do is get the baby on mom if it wasn't already, and then put warm blanket over both of them. Okay. So our different ways of losing heat. So convection is going to be a flow of heat from the body surface to the ambient air. And so we decrease that losing heat by convection by wrapping the baby, using a hat, and decreasing exposed skin. Evaporation is a loss of heat when liquid is converted to vapor. So very important right at delivery that we dry the baby off, and we also remove the wet blankets. Conduction is a loss of heat to a cooler surface in direct contact. So what that means is if I put a warm baby on a cold scale, the baby's going to lose heat to the scale. So pre-warming our warmer, using a warm stethoscope, keeping baby skin to skin, putting a blanket, like a warm blanket on our scale, and then zeroing it out before we put the baby on it, things like that are all helpful to reduce heat loss by conduction. And then radiation is a loss of heat to a cooler solid surface in close proximity. So if we put a baby close to a window and it's drafty, then we can get a cold baby. And so we're going to minimize that also with skin to skin and keeping the baby away from cool drafts. So transitioning to extrauterine life, this is like the first 6 to 8 hours after birth. And so babies come out and they have this period of reactivity where they're really alert and they're really interested. This is when they're spending a lot of time skin to skin with mom. And this is a great time to get that first breastfeeding done. Okay. After that, they get into a period of decreased responsiveness. And so then things slow down. They get real tired. Their breathing slows. It's still in the normal range, but it's going to become a little more regular. Okay, so we have irregular breathing at first. Now we're a little more regular. And then during this time, babies might be less interested in eating. Then we have our second period of reactivity. Now our baby is more alert again, and so kind of keeping that in mind as we are assessing our babies. Here in the first 2 hours. So immediately after delivery, we are putting baby skin to skin so that we prevent cold stress, we promote thermal stability, we promote bonding, and we get baby breastfeeding. We're going to, in the initial time, we're going to put the little security tags or identifications on the baby. And we are watching for pees and poops. And we do our little assessment and see if the baby looks like everything looks good. If they have any signs of injuries, like if there's a shoulder dystocia, we're assessing like for clavicle fractures and things like that. Babies get typically 3 medications, definitely 2. The hepatitis B vaccine is offered and most often given in the places that I've been. So babies get eye ointment that is erythromycin. And so this is going to help to decrease the incidence or prevalence of ophthalmia neonatorum, which is a conjunctivitis that they can develop if mom had gonorrhea, especially, but also chlamydia. We can see it with that as well. We give this to all babies because we don't know, even if mom was negative for these things at the beginning of pregnancy, we don't know if she was exposed to it during pregnancy. And it's a pretty easy thing to do for all babies, and it has a great benefit. Vitamin K prophylaxis. So this is phytonadione, and we give this as an IM injection. So babies, when they're first born, they're lacking in clotting factors because that they need vitamin K, and the newborn gut is sterile and they don't have that yet. And so we have kind of, it takes them about a week for this all to establish itself. And so by giving vitamin K, we are decreasing the risk of bleeding for our babies until their bodies start synthesizing prothrombin in the liver. And so then the hepatitis B is the other vaccine we can give that is recommended by the American Academy of Pediatrics, that babies get the first dose in the hospital, and then they get the other 2 doses on schedule in the clinic, but parents can choose to decline and to wait. Newborn security. So this is an example of a HUGS tag. A lot of hospitals are going to this. It's an alarm system that will notify if the infant is removed from the unit. It also notifies if you tamper with the band that has the monitor on the baby. We also encourage moms to keep the baby on the opposite side of their bed from where the door is, so that anybody that's coming in to see the baby has to actually walk all the way around to get to the baby. Most of the time, the badges that we wear on OB are special just for that unit. So it's easy to identify when a nurse or a doctor walks in that belongs on that unit versus one that does not. And then anytime you take the baby for testing or whatever, and you bring the baby back, you should check and match the identification bands between the mom and the baby. Physical assessment for our baby. So make sure we're doing it on a warm surface, right? So either on the warmer or on an area that's been pre-warmed. Like if I'm weighing the baby, I put a warm blanket on the scale first. We'll do our neurologic assessment so we can check the reflexes. We also will check the baby's suck reflex. And when I check the suck reflex, it also gives me the opportunity to feel the palate. And so that if we have, if we didn't know that we had a cleft palate, then I can feel it with my finger. We're going to assess the vital signs. So normal vital signs for a baby, the heart rate should be the same vital signs as what we saw in utero. So 110 to 160. Respiratory rate 30 to 60 is normal. Now, the thing to remember for babies is that their breathing patterns are very irregular. So you should be listening for a full minute, but also know that if babies can have these pauses as they're breathing up to 20 seconds, and that's okay. So if your baby doesn't take a breath and it's 18 seconds, that's fine. Which is also why it's important to listen for a whole minute, because typically if a baby has a pause in their respirations, then they're going to have compensatory afterwards, and so then they'll breathe really fast. So if you're only listen for like a short period, like 15 seconds or 30 seconds, you might be listening during a pause, or you might be listening during the compensatory part, and you're not going to get a really accurate idea of what their actual respiratory rate is. Temperature, 97.7 to 99.5. I really like my babies to be greater than 98.0. So if we're getting down close to 97.7, even though that's still the low side of normal, I try to get that baby back on mom's skin. It's their favorite place to be anyway. Weight is 2,500 to 4,000 grams is normal. So if our babies are less than 2,500, they are considered small for gestational age. And if they're greater than 4,000, they're considered large for gestational age. Average for gestational age is going to be between the 10th and the 90th percentile. Babies that are small for gestational age or large for gestational age have risk factors like increased risk of hypoglycemia is a big one. And then we're doing our measurements. Okay, so 18 to 22 inches is normal for length, and then the head circumference of 12 to 15 is normal. The chest circumference is going to be very similar to the head circumference unless you have a baby that has what we call asymmetric IUGR, and that's asymmetric intrauterine growth restriction. And that often we'll see that with moms that have had a chronic condition during the pregnancy, like preeclampsia. It affects the way the baby grows. So for hypoglycemia, risk factors for hypoglycemia, the biggest risk factor to develop hypoglycemia is going to be if you're born to a diabetic mom. Okay, but also preterm and postterm babies, LGA and SGA babies. We also can see hypoglycemia when moms receive tocolytics in labor. That's not as common. And then cold stress. So if the baby gets cold, the baby's body starts burning its own brown fat for heat, and it causes this cascade that uses uses up the glucose, and the baby becomes hypoglycemic. So oftentimes cold stress and hypoglycemia go together. So signs that our baby is hypoglycemic, oftentimes we see a jittery baby. They're just really, they look almost tremulous, okay? But we can also see poor muscle tone where they can be kind of hypotonic. They could be diaphoretic. They could have signs of respiratory distress. So tachypnea is a big one. Again, low temperature, because sometimes the two go together. High-pitched cry and lethargy. If it's severe, they could also have seizures. When we're doing our assessment, we can assess for gestational age. The things that we're concerned about with our babies for gestational age is if your baby is, so remember term is between 37 weeks and 41 and 6. Is your term baby. If your baby's less than 37 weeks, they're going to have a higher incidence of respiratory distress. They're going to have a higher incidence of temperature instability, hypoglycemia, hyperbilirubinemia, and feeding difficulties. These are going to, and the younger they are, the bigger the problems will be. But it's really our late preterm infants from 34 to 36 and 6 that these are kind of the things that we're always watching and assessing and working on with them. Our post-term infants, 42 weeks and greater, these babies can be bigger. They can be macrosomic. They could have a birth injury from delivery. They could have meconium aspiration syndrome, because that babies that go over 40 weeks have a higher incidence of releasing meconium. And so they might have released meconium and they aspirated it. And that's when we start seeing signs of respiratory distress like tachypnea. And then when we're assessing for gestational age and just eyeballing them, we look at how much vernix do they have. So vernix is that white kind of cheesy stuff on their skin, and more vernix the younger they are, and then less so the older they get. How long are the fingernails? The texture of the hair. The skin, is it transparent? So transparent is a really young baby. Peeling is an older baby, like close to past 40 weeks. The sole creases. So a young baby's feet are very smooth, and then the sole creases increase as they get closer to their due date. the ears, the genitalia, all these things we can look at to kind of determine how young or how old gestationally our baby is. Okay, so now we're going to just move on a little bit to breastfeeding. So benefits to for breastfeeding for the baby, there's numerous. Okay, there's a lot of data that says that breastfeeding reduces the risk of things like ear infections, respiratory infections, GI infections, asthma, SIDS, all of that. Okay, for your babies that are born preterm, breastfeeding improves neurocognitive outcomes and greatly reduces the risks of sepsis and necrotizing enterocolitis. That is, actually, breastfeeding is the only thing that really has been shown to decrease necrotizing enterocolitis, which is something that can cause bleeding in the GI for our preterm babies. Benefits for mom. So remember that when she latches her baby and the milk lets down, her body releases oxytocin to help the milk let down. So it's going to help the uterus contract. So more rapid uterine involution, decreased postpartum bleeding. Also shown that breastfeeding decreases her risk of certain types of cancer and other conditions like heart disease. Breastfeeding is going to be more convenient for the most part. It's just right there. It's ready. You don't have to warm it. You don't have to thaw it. You don't have to mix it. It's just already ready to go. And obviously it's less expensive. So for breastfeeding initiation, important to teach moms to be able to identify feeding cues for their baby. Because if we're trying to get the baby to eat and we waited until the baby is frantic, they're not going to latch well. And so teaching signs like the mouth and tongue movements or rooting is a good way to help moms build confidence to know when their baby needs to eat. We want to initiate breastfeeding, as we said, in the first hour after birth, if possible. Immediately after delivery is fine if the baby's interested. We will keep the baby skin to skin and delay all of our routine procedures, usually till after baby eats. Okay. If this baby ends up going to the NICU or is separated from the mom for some reason, we can get mom pumping. And she just needs to pump 10 minutes on each side every 3 hours. And that's going to help her bring in her milk. Any of the drops of colostrum she gets with pumping, we can give to baby. Okay. The other thing that's important here, even with this first feed, is working on latch and making sure that we get a good latch from the start. This, I believe, is pretty similar to the slide we had for breasts. So the thing that to note is the 3 phases of milk production. So colostrum is first, and that's where all those protective antibodies are. And then we get transitional milk and then mature milk, usually about 3 to 4 days after delivery. So positioning and latch, this is the priority assessment from the very first feeding to help prevent nipple damage and soreness, which we talked about earlier today. We can use a latch assessment tool that looks at latch, audible, swallow, the type of nipple, the comfort of mom, and the holding position. The thing that's important for this, guys, is that we need the baby to open the mouth really wide and to take the whole nipple and areola. Okay, because the nipple needs to be into the soft part of the baby's mouth. And that's going to help get the baby good milk transfer because their gums are going to massage the milk ducts and help bring the milk in. And it's going to minimize tissue trauma for the nipple. So it looks like this.
All for you and your baby. To understand how latch-on affects your comfort, let's look inside at the roof of a baby's mouth. Behind the baby's gums are ridges. Behind the ridges is the baby's hard palate. When your baby takes your breast into his mouth, if your nipple lands near the front of his mouth, your nipple will press against his hard palate. This is called a shallow latch, which can cause discomfort for you as he breastfeeds. If your baby breastfeeds with a shallow latch repeatedly, the friction and pressure may eventually cause you pain or even skin damage. Farther back in your baby's mouth, the palate changes from hard to soft. Some call the area near this soft palate the comfort zone. To get a better idea of where this is, use your own tongue to find your soft palate. When your baby takes your breast deeply into his mouth and latches on so that your nipple lands in the comfort zone, there is no undue friction or pressure as your baby breastfeeds. Latching on within the comfort zone is where breastfeeding is most comfortable for you and most effective for your baby.
So that is a proper latch. So for breastfeeding, when the milk lets down, sometimes the mom feels kind of a tingling sensation in her breast, but also remember that her after pains can be stronger. So she might get more crampy when she's feeding her baby. Babies, when they get on, they suck quickly to get the milk to let down, and then you'll see long sucks and start hearing audible swallows. Oftentimes when the milk lets down, the other breast will leak, the one that the baby's not on. Babies should be fed every 2 to 3 hours, and until the milk comes in and the baby has kind of turned the corner on weight loss, because babies tend to lose weight in the first few days of life, we do encourage parents to wake their baby to eat and stay on that schedule. But we also are going to be teaching on-demand feeding. So watching for those feeding cues. If the baby wants to eat, even if it's been less than 2 hours, the baby should eat. Okay. We don't want the baby to go over 3 hours in those first few days of life, but definitely they can eat more frequently. And oftentimes they do. On the second night, babies do cluster feed to try to bring the milk in. We keep babies rooming in, and we teach that following a strict schedule can affect their ability to meet their nutritional needs. That means, so if they want to eat more than every 2 hours, they can. Okay. Typically duration is 15 to 20 minutes per breast. Some babies are more efficient, some less so. The baby should empty the first breast completely before offering the second side, because the hin milk that comes out last is kind of like dessert, and it's high in the fats the baby needs. And then we'll offer the second breast at the next feeding first to try to keep it even. How do I know my baby's getting enough to eat? So this is a question that comes up over and over and over. For the mom, when her milk comes in around day 3 or day 4, she should have a lot to start. So we talked about that in relation to engorgement. She should, during the feeding, feel tugging sensation on the nipple. It shouldn't be painful. She should feel her uterus contracting, which is normal because of the release of oxytocin. She might feel letdown happen when that tingling happens. And then the breast should feel soft after delivery. After feeding. For the baby should be able to latch without difficulty. The baby should have bursts of sucks and swallows. So again, rapid and then long and slow. Audible swallowing. After the baby is past day 4, the baby should be having 6 to 8 wet diapers per day. And that is a really good indicator that the baby is getting enough to eat. If the reason we say after day 4 is because in the first 24 hours of life, the baby really only needs to void once. And then in the second 24 hours, the baby needs to void twice. And so by day 4, where everything is well established. And so then we're thinking 6 to 8 wet diapers per day. And your breastfed baby should also be having 3 bowel movements per day at least. And the newborn breastfed baby stools are like this. Once it transitions from meconium, it's like a mustardy yellow, seedy looking, kind of loose, soft stool. So care for the breastfeeding mother. So we're going to let her know and encourage her to have 500 extra calories per day, making good food choices. So not getting those 500 calories from empty places, but good, promoting good nutrition. No soaps on the nipples because of cracking and bleeding, and also avoiding creams and lotions. She can use a nipple solvent that, oh my gosh, I'm drawing a blank on what it is. Lanolin. Sorry, she can use lanolin on her nipples, and that's very soothing, and then she just will wipe it off before breastfeeding. And that is a safe choice. We need to teach moms that are breastfeeding that breastfeeding is not a form of birth control. Oftentimes when moms are breastfeeding, they notice that they don't immediately restart a period after having their baby, but we don't know at what point they will ovulate. And so they should be mindful of that and not use that as birth control. Oftentimes women will become pregnant and not even know because they didn't know that they ovulated. If moms are choosing oral contraceptives after delivery and she's breastfeeding, she should take ones that don't contain estrogen because that will affect her milk supply. If she does become pregnant again, she can continue to breastfeed. And then also teaching that to be mindful that any alcohol or caffeine or medications or any of those things, everything passes through the breast milk. And so some things are safe with breastfeeding and some things aren't. And so if she needs to consult with her provider for certain medications. If she's taking things that aren't safe with breastfeeding, she can keep her milk supply up by pumping and dumping the milk that's not safe for her baby to take. But keeping in mind too that since everything crosses the breast into the breast milk, that if she's on an antibiotic, her baby can develop thrush and things like that. So for engorgement, we talked about this in relation to the breast. When the milk comes in, the breasts get really tight and full. So ice packs between feedings is good. Anti-inflammatory medication is good. Hand expressing is good. Heat before or during breastfeeding can help the milk let down. So that's an option also. Have her feeding frequently. For her sore nipples, we need to assess that we have a good and correct latch to start. We can give her lanolin. There's also like gel pads that she can use that that just puts coolness on the nipples. And then she can also apply breast milk to her nipples, so that can help as well. Insufficient milk supply, typically we just are encouraging mom to increase feedings because it's a supply and demand system. So frequently emptying the breast is going to help, but this does seem to be the time that causes moms to stop breastfeeding most frequently. There are some pharmacological and non-pharmacological things you can do to try to increase milk supply. There's things like mother's milk tea and things like that. And then weaning. So we're not teaching weaning in the hospital, but we would be teaching weaning in the clinic. There's not really a good time to wean. It's going to be completely based on preference. We usually encourage moms to eliminate one feeding at a time and to do it slowly and to save the favorite feeding for last. And then if she's trying to wean, then she shouldn't be pumping because she wants to let her milk supply decrease gradually. So gradual weaning. For our formula fed babies, for moms that are choosing to formula feed, there are a lot of reasons why. So it might be their own preference. It might be that they had a bad experience with breastfeeding before. It might be that they have a contraindication to breastfeeding, like TB or HIV or herpes. If a baby is not breastfeeding, they should be provided with a commercial iron fortified formula. And the iron fortified formula is going to provide them with the nutritional needs that they need. It's not the same as breast milk. in a lot of ways because breast milk has things you just cannot duplicate because breast milk is dynamic and constantly changing to meet the baby's needs. But formula is a good second choice. So we're going to teach how to prepare formula properly. One thing that's really important is that they're not, even with formula or breast milk, that they're not heating it in the microwave. Okay. And then how to know how much to feed. So babies' stomachs are very small. And if we overfeed in the first 24 to 48 hours, these babies are going to just throw up. So no more than 15 to 30 mLs per feed in the beginning. And then as the baby grows, then we increase the amount per feeding. Bottle-fed babies feed a little less frequently. So every 3 to 4 hours instead of every 2 to 3. We still don't want to keep these babies on a rigid schedule either. So encouraging moms to be mindful of the time is going to be, we want to encourage them to feed at least every 3 to 4 hours, but to still let the baby eat sooner if they want to, is what I'm trying to say. Babies that are receiving bottles should be held and the bottle shouldn't be propped. If you lay a baby down and prop a bottle, the milk or formula collects back and can cause ear infections and dental caries. And then we teach how to burp the baby, and they should burp the baby several times to decrease spitting up. And then discharge planning and teaching. So when it's time for them to go home, there's a lot of different things we're teaching about. Babies for temperature, we tell them to just 1 layer extra than what you would use. So they don't need to overwrap and make the baby too warm. If the baby does have a fever greater than 100.4, they should call the doctor. For respiratory, we want to teach how to use the bulb suction. Okay, they need to know how to do it. We want to show them what variations in the baby's breathing patterns are normal. This is important because remember we said that babies can have respiratory pauses up to 20 seconds. I remember with my first baby, nobody told me that. And I was like, my baby's not breathing. Okay. So teaching the normal variations for respirations is important. Also teaching signs of respiratory distress. Okay. Feeding patterns, so on-demand breastfeeding versus formula, all those things we just talked about. Elimination, so the way the stools transition from meconium to transitional stool to breastfed baby stool, 6 to 8 wet diapers per day. Sleeping and positioning, we want to encourage back to sleep, so we're teaching about safe sleep. So on their backs, the head of the bed can be elevated 15 degrees, and then about swaddling, how to swaddle a baby. Babies should sleep with just like there's you can do like again an extra layer. So there are swaddles you can use that have like a Velcro and things like that are helpful. Rashes, so that contact dermatitis, newborn rash, diaper rash, things like that. We'll teach them about clothing 1 more layer than yourself. Car seat safety, how most places show them how to install the car seat safely, and we need to actually see that there is a car seat, the baby is buckled into it correctly, and it is installed correctly into their vehicle. We're going to teach about non-nutritive sucking. So what this is this is your pacifier. And so we encourage women to wait to give their baby a pacifier until breastfeeding is well established, the milk has come in, the baby's eating well, before offering the pacifier. But there is a definite benefit to using a pacifier, especially during nap times, and it's been shown to prevent SIDS or reduce the risk. Teaching about bathing. And so we're going to encourage sponge baths only until the umbilical cord falls off so that it can dry and fall off. Typically, water is fine. They don't have to have soap, but if they use a soap, then it should be a mild baby soap that is rinsed off well. For the umbilical cord, we want them to keep it dry, keep it clean. They don't really need to do anything with it except gently clean it with some water if it gets soiled. Otherwise, we're going to encourage them to leave it alone. We encourage all parents to take a CPR class and to know what to do if their baby is choking or stops breathing. We can teach them how to soothe. So different ways to soothe their baby and help a crying baby. Also safety for that. If the baby is crying for a long time, it's okay for them to put the baby down and to walk away. And that's part of like your Don't Shake a Baby initiative. For immunizations, we're really just going to encourage them to follow up with their pediatrician within a couple days after discharge and to follow their immunization schedule. And then well baby checks will start. In here it says 6 to 8 weeks. I do think that oftentimes the pediatrician sees the baby at 2 weeks as well. And that is the end of that. I hope you guys have a great day.